Hi, my name is Allan Kirk. I'm the chairman of surgery for the Duke University School of Medicine, and in the context of this lecture, I'm one of the kidney transplant surgeons at Duke University Hospital. My lecture today is going to highlight some of the new advances in immunomodulation for preventing rejection for kidney transplantation, and specifically to talk about one of the most recent advances in immunosuppression, that being co-stimulation blockade. Shown on the slide here is a condensed history of transplantation demonstrating the acquisition of various immunosuppressive agents and improvements of outcome. You can see that early in the 1960s, when kidney transplantation first began, outcomes were relatively dismal. The rejection rates were high, the survival rates were low, and the options for immunosuppressive management were limited to prednisone, 6-mercaptopurine, and radiation. Over the period of time over the next couple of decades, we had a gradual increase in the types of medications that could be brought to bear to prevent rejection, and you see a very specific inflection point around the 1983 time point when the calcineurin inhibitor cyclosporin was introduced. That represented a revolution in the ability to prevent rejection, and you see in this graph the rejection rates decreased dramatically after that period of time. The survival rates increased substantially as well. Over the next several years, many other agents have come to be made available to kidney transplant surgeons, and in fact now the chance of rejecting a kidney transplant in the first year is very, very low, particularly when patients take the medications as directed, and the survival rates are very, very high. Thus, the major issues with kidney transplantation are not related to survival or rejection rate, but rather to the proper management of the medications, the many medications available to prevent rejection. As an example of that, I show a single day's supply of medications for a kidney transplant patient. This is a patient's medications for an individual that was on prednisone, mycophenolate mofetil, and cyclosporin, which is a very common combination of medications worldwide. And you can see that this really exemplifies the extraordinary measures that individuals have to go to prevent rejection. These aren't just inconvenient problems, but they also have many side effects, including a worsening of the risk of infection, a worsening of the risk of malignancy, and indeed some of the medications, in particular the calcineurin inhibitors, which revolutionized the rejection rates, are actually nephrotoxic. And it seems counterintuitive, of course, to have to take a medication that has kidney toxicity to prevent kidney transplant rejection. And so we have been very interested here at Duke in trying to understand ways to prevent rejection without relying on so many medications, or at least when we do need to rely on medications, to think through the process so that we use as few medications as possible. So whenever faced with a significant medical problem, it's always good to go back to some of the fundamentals. And in this circumstance, we're trying to understand the fundamental components of an immune response, in particular, an immune response of the recipient to the donor organ. And as an analogy, I think it's safe to consider this as the fundamental components of a decision. Because an immune response, of course, is really your body's decision as to what to do with a new or unrecognized antigen or entity. So if you think about how a decision is made, not just immunologically, but in any circumstance, there's a component of specificity to that decision. In other words, what is it that you're going to be making a decision about? There's a component of context. Is this the right time or the right place to make a decision? And then once you've decided to make a decision, you have to decide what amplitude that decision should be. Should it be an aggressive, very strong response, or should it be a more nuanced response? And in fact, immunologically, the body uses these same tenets to determine whether to respond to something new or not. In the circumstance of the immune response, it's usually a decision being made by a lymphocyte, shown diagrammatically on this slide. Antigen, or the antigen receptor, is the signal of specificity. This tells the lymphocyte what it is going to make a decision about. It does not say what it will do, but it just alerts the lymphocyte that it is recognizing something that has gotten its attention. We call this signal 1. The contextual signals are known as costimulatory molecules. There are many costimulatory molecules, and it's not necessary to go into the details of those for this lecture, except for to indicate that this provides context for the signal of specificity. We call this signal 2. And then finally, there are a number of different molecules that change the amplitude of an immune response. Many of these are driven by cytokines or other soluble molecules, and this determines whether the response is a large response or a small response. And many of these signals drive whether the cell involved divides to many cells or stays a single cell. Now, it is typical that people think of co-stimulation as being just an on switch, but in fact it can be both an on or an off switch, such that when you see something, when your lymphocytes see something, they can make the decision not only to attack it, but actually to retreat. And thus, if we base our immunosuppression solely on signals 1 and 3, those being specificity and amplitude, which are what most of the transplant medications to date have done, we can decide whether we will have a reaction against something or not, or we can determine whether it's a big reaction or a small reaction, but we really can't give the nuance of whether it's the right time or place. So our group and many others have been looking at the signal of context, the co-stimulatory signal, to try to finely manipulate the immune system so that an individual can prevent rejection of their organ, but not prevent rejection of bacteria or tumors. So there are many different types of co-stimulatory molecules that will be shown diagrammatically on this slide. Again, signal 1 being the specificity signal is shown here with the T cell receptor binding to the MHC molecule. And the most studied co-stimulatory molecule is one called CD28. When your lymphocyte detects something foreign with its antigen receptor and CD28 is present, this provides a positive context to encourage the T cell to have an immune response. Interestingly, when that immune response occurs, another molecule comes up on the surface known as CTLA4, also known as CD152, and this molecule elegantly competes for the same molecules that CD28 bind to. And indeed, when this molecule binds and competes away from CD28, it turns the immune response off. Thus, built into the beginning of every immune response is the mechanism to turn it off. This prevents too much immune activation and helps you control immune responses. Now, you can take antibodies or drugs, proteins, that can bind to these different molecules and, as shown here, block the interaction with CD28. Unfortunately, there are no medications available clinically right now that solely block CD28. There are molecules that block CTLA4. These molecules actually prevent the turning off of an immune response and are used to help increase an immune response toward a cancer. But of course, in the context of a transplant, this would be harmful. And you can also block the opposite side of this response, the molecules B7-1 and B7-2. In this circumstance, you prevent the positive context of CD28, but you can also prevent the negative context. So what this does is allow a cell to recognize the donor, for example, but prevents the positive context of the immune response. Of course, there are many agents that could prevent any of these, but the ones that are most common are ones that block the B7 molecules. And indeed, the one that is now available for transplantation, a drug called belatacept, is a fusion protein where the CTLA4 molecule has been engineered to be able to block the B7 molecules, and actually prevent CD28 from driving an immune response forward. There are many other co-stimulatory molecules that provide either positive or negative influence toward the immune response. None of them are clinically relevant at this time, but suffice it to say that the immune system has learned through these molecules to very finely tune its immune response to almost everything it encounters, and our ability to tap into that fine control is what's now allowing us to prevent rejection without preventing so much of the immune response toward viruses, bacteria, and cancers. We'll talk a little bit more now about this particular molecule known as belatacept, also known as CTLA-4 Ig. This is a molecule that's been around for about 20 years, and in fact, when it first came to the scientific literature, it was shown by an investigator named Chris Larson that the use of this drug in a mouse model of transplantation allowed mice to get heart transplants treated only for just a couple of days with this context inhibitor, and it allowed these mice to keep their heart transplants indefinitely without the requirement for additional immune responses or immune suppression. Indeed, mice also were given skin grafts and shown to be able to prevent rejection of skin grafts with just a small amount of medication given right at the time of transplantation. The way you can put this together is that when an organ is seen without the context of a positive signal, that the body interprets that as being benign. It interprets it as being okay. And in fact, by doing that, once that decision is made, subsequent decisions are shaped by that initial decision. It's very much as though the first time you experience anything, if you experience it in a good context, the next time you come to be exposed to that, you're likely to expect the outcome to be good. Now, an important part of this experiment was that when cyclosporin was given to these animals, it actually prevented the drug from working. And this demonstrated that an important component of this drug working is allowing the recipient to recognize the donor and then blocking the dangerous context. This is really teaching the immune system to accept an organ as opposed to just preventing it from being rejected. Our lab took these findings and applied them in larger animal models, including non-human primates, and were able to demonstrate that even in the complex outbred world of non-human primates, you could prevent rejection of a kidney just by using a short course of these co-stimulatory agents and then allowing you to stop the medications for weeks or even months without having a rejection response. We did demonstrate that the body remained able to recognize the donor throughout all of this, but that by blocking the context of CD28, that these animals were able to enjoy long-term kidney survival without having to be on daily immunosuppressive agents. These drugs eventually were brought to the clinic, and the drug CTLA-4 Ig, or abatacept, was improved to create a drug LEA-29Y, which is now known as belatacept. This drug has a higher affinity for the B7 molecules, and this is the drug that was brought forward by a company known as Bristol Myers Squibb to be developed into a drug for transplantation. This drug was used in a clinical trial, a phase 2 clinical trial, and shown to be able to be used as a substitute for cyclosporin, and subsequently a large pivotal trial was performed demonstrating that people treated with this drug instead of cyclosporin had better kidney function than people treated with cyclosporin. In this slide, you can see the kidney function of people on the pivotal phase 3 trial, showing that people that are on belatacept and not on cyclosporin had better kidney function throughout the duration of the trial. This is not hard to understand because the drug cyclosporin has kidney toxicity and the drug belatacept does not. Unfortunately, one of the other things that was noticed during this trial is that individuals that had belatacept instead of cyclosporin had higher rates of rejection. And this is something that our lab has been very interested in looking at over the past several years to try to understand the nature of this increased rejection rate. Now, to be clear, individuals that have rejection on belatacept still typically maintain their kidneys and over the long period of time have better kidney function than individuals on cyclosporin or similar calcineurin inhibitors. Nevertheless, this early rejection episode, while the kidney is getting to know the immune system of the recipient, is something that we'd prefer to do without. So the prevailing questions in understanding how best to use this new drug are: what is the nature of this belatacept-resistant rejection? What are the best therapies that we can pair with this drug to improve the efficacy of belatacept? And can we identify patients ahead of time who are likely to have a rejection episode so that we can avoid it up front? Now, this is a relatively complex readout from a particular immunological study, but it basically demonstrates that lymphocytes, each one of these dots on this graph is a lymphocyte that's been run through a machine called a flow cytometer, and it looks at the fluorescence of these cells and then tries to determine which molecules are present on these cells. What you see here are cells divided out by whether they express the molecule CD2 or express the molecule CD28. You'll recall that CD28 is the molecule that is so important to the context of an immune response. And you see that cells that fall into the CD28 negative compartment are cells that are all in the lower quadrants of this graph, and these are quadrants that are where what are called memory T cells live. So these are cells that have already seen something, already become activated, and in the process of becoming activated, they have lost the molecule that belatacept rejects. Now you might ask yourself, why does this happen? Well, again, when you experience something for the first time, it's very important to try to establish the context of that initial encounter. But once you have experienced that and determined what the right response is, you shouldn't have to go back and ask whether the context is favorable or not for your second encounter. And so when the body encounters something, it typically loses this molecule so that the next time it can respond more quickly. This is why it's much better to prevent rejection of the graft at the beginning rather than trying to prevent rejection later on. Interestingly, as people have been followed over time, we find that the older a person gets, the more likely they are to have CD28 negative T cells. In this graph, you see that individuals measured for the amount of CD28 on their cell surfaces, the amount goes down over time, and the number of cells that are categorized as memory T cells go up over time. And indeed, on the bottom, if you really follow the number of naive T cells, in other words, the number of lymphocytes that have not yet committed to an antigen, that over time, by the time you're 90 years old, almost every cell in your body has already committed. Indeed, lymphocytes are very much like people, that once they learn something, it's hard to unlearn it, and by the time you're in your 90s, you've pretty much decided how you're going to respond to everything that you're going to encounter. So rather than thinking about the cells that reject an organ as being one group of cells and the cells that reject organisms like viruses and cancers, what we've now come to understand is that while there is a repertoire of cells that can reject your kidney, and there are repertoires of cells that have already gone to battle against viruses, tumors, and things along these lines, that these two populations of cells overlap, and when they do overlap, that you can develop a memory response against an individual that you have never yet seen. It's almost a way of developing rejection against people by proxy. And so this is why we need adjuvant agents to help belatacept get settled into a situation that's okay for you to use this medication. Now, one of the first hints as to the type of adjuvant medications that are used came from these two articles published in Nature Medicine about a decade ago, demonstrating that when you use cyclosporin, you inhibit the ability of these co-stimulatory molecules to make an appropriate decision. Very similar to the mouse studies that I told you about of Chris Larson. But they did find another medication, a drug called sirolimus, that blocks another signal that's quite compatible. And indeed, our group began studying this drug, sirolimus, to find a method of transplanting patients without having to use cyclosporin, and in such a way find a drug regimen that could be paired with belatacept and allow an individual to have the adjuvant blockade with belatacept. This is a study we published in The Lancet about a decade ago, demonstrating that patients could be transplanted with this drug sirolimus. We subsequently studied a new drug called Allan, which is a drug that depletes T cells and gets rid of many of the memory T cells that are formed during life, and indeed took depletional agents, a drug like belatacept, CTLA-4 Ig, and sirolimus, and put them together in a kidney transplant model in non-human primates. We were able to demonstrate that these drugs combined were safe to use in people and would prevent rejection. We optimized this over a number of studies, the most recent published in 2013, and are now coming forward with new ways of preventing transplants from rejecting by blocking co-stimulation with belatacept, blocking the cytokine signals with sirolimus, but allowing the antigen signal to go forward by not having to use a calcineurin inhibitor. And in doing so, the individual can learn to accept a graft because it can see that graft through its antigen receptors, but it doesn't see the danger of a positive context here. This is one of the trials that we've just recently completed. It shows the drug regimen. Basically, a single dose of alemtuzumab is given at the time of transplantation. Belatacept is given every 2 weeks and then eventually once a month. And sirolimus is given daily for the first year and then weaned off. This was reported about a year and a half ago now. This demonstrates the kidney function in patients that were treated with this new approach. You can see on the left that the kidney function levels, the creatinine, are quite normal and stable. And on the right, you can see that over a period of 3 years that patients in this trial maintained excellent kidney function over time. This demonstrates the first 20 patients that we put into this trial. We treated 20 patients with this regimen, and all of them did well in the first year, and were evaluated to start decreasing the amount of immunosuppression over time. This is very unlike most transplant trials, where individuals, once on an immunosuppressive regimen, need to stay on that regimen forever. But in this circumstance, if the body is really learning to accept the organ over time, that the amount of immunosuppression should decrease. For various reasons, 17 of these 20 patients were eligible to decrease their immunosuppression, and 10 patients chose to do so. 5 of these individuals were able to wean off of their sirolimus, so that rather than having a handful of pills to take every day, they took one medication once a month by vein, and that was the only medication needed to prevent their kidney from rejection. 5 patients, when they withdrew from their sirolimus, had an inflammatory response toward their kidney. Most of these were recognized on protocol biopsy. It didn't actually change the function of the kidney, but it made us put the patient back on a small amount of sirolimus. 2 of these individuals eventually came off of that drug, such that of the 10 patients that we initially started the trial with and attempted to wean, 7 of those individuals were able to come off all of their daily immunosuppression and just take a single medication once a month. And the other 3 of those individuals stayed on a once-a-day regimen of sirolimus without the requirement for steroids and without the requirement for calcineurin inhibitors. All 20 of these individuals did well longer term. Now, if you look at the blood cells that these patients had, you can see across the top that the standard white blood cells, the granulocytes, which are the cells that help you prevent bacterial infection, and the monocytes, which are the cells that respond initially to an infection. These cells were not impacted by this therapy in the least. The lymphocytes, which are the cells that can cause kidney rejection, were depleted and then repopulated over time. And this repopulation was a chance for the lymphocytes to become in contact with the kidney with the contextual signal blocked by belatacept and allow them to encounter the graft for the first time without any signals that would indicate that the graft is causing harm to the individual. So as we look at the T cells and B cells shown on this graph as T cells being CD3 positive and B cells being CD20 positive, that these cells grow back over the first year. And interestingly, if you look at the cells growing back, the T cells growing back in the upper panel, you see that these cells become very activated during the first year. This is recognized in this study by a marker called Ki67, and you can see that all the T cells, when they're growing back, are becoming quite activated. Basically, they're trying to grow back into this void that's been left by the T cell depletion, and during that rapid period of growth, there is a rapid period of education. It's very much like allowing the T cells to go back through childhood again, but in the context of the new kidney that's been placed. If you look at this type of activation and then look in people that receive regular standard of care immunosuppression, for example, cyclosporin or tacrolimus-based immunosuppression, that this period of education does not occur. Again, if you're blocking signal 1, you're blocking the signal of specificity, you're preventing the immune system from seeing the graft, and therefore the immune system cannot learn to accept the graft. In this particular regimen, though, the kidney is allowed to see the graft, it's allowed to grow the lymphocytes in this context, and by blocking the contextual signals of danger with belatacept, the immune system gradually learns to accept this kidney. There are many types of cells that you can measure in these individuals that have what are called regulatory effects. On this, there are 4 types of cells shown on this slide. Regulatory T cells in the upper left-hand corner, transitional B cells, regulatory B cells, and what are called gamma delta T cells. All of these cells are known to control out-of-control immune responses, and all of these cells become very prominent while your immune system is growing back. And then as the immune system comes back to quiescence after a year, these cells come back down, and it's at this point that you can withdraw the sirolimus and allow an individual to get to a much lower state of immunosuppression. If you measure the amount of memory or naive cells that are seen in these patients, you'll see that as in the green, the number of naive cells actually grows with time, and the number of memory cells decreases with time. This is quite the opposite of natural aging, and again allows an individual to reboot their immune system in the presence of their new kidney. Again, looking at these same processes, comparing the belatacept-treated patients to standard of care patients, you don't see the same types of therapy. B cells, the same types of things happen. This is a very complicated slide. The details of it are not particularly important, but what it shows is that individuals that go through this type of therapy have a maturational arrest of the cells that are trying to go after the kidney, that they arrest before they can make antibody, and because of this, these individuals not only don't have rejection, cellular rejection to their kidney, but they also don't have antibody responses to their kidney either. Now, you may ask that while all this is happening, what's happening to the ability to recognize viruses? Well, interestingly, viral memory is very well entrenched by the time most people come to transplantation. And in studies that we have done looking at cytomegalovirus responsiveness or Epstein-Barr virus responsiveness, indeed, over this period of learning, the memories of cytomegalovirus and Epstein-Barr virus immunity are unchanged. And thus, while the individual is specifically learning to accept the kidney, it is not erasing the memory that it needs to protect the individual against viral infection. So the first thing you should always do with an experiment is to repeat it and see if it works again. And in fact, we have done just that. Only in this second experiment, we've done patients that are not just live kidney donor recipients, but also have received deceased donors. This is a little more difficult circumstance. We've also allowed individuals who have antibodies against other people to be enrolled in this trial. And so this has really been an all-comers type of verification of this trial. The therapy has been the same, and the outcomes have been largely the same. In this next cohort of 20 patients, we've transplanted 10 recipients of deceased donor kidneys, 10 recipients of live donor kidneys. All of these individuals have clinically done well. The follow-up at the time of this taping is almost 2 years, and indeed these individuals are starting to be weaned down to single once-a-month therapy as well. The second group of patients' outcomes can be shown here. Their kidney function at 6 months is extraordinarily good. And indeed, if you follow the function of these individuals over the first 2 years, the kidney function actually increases over time, despite the fact that the amount of immunosuppression they're receiving is decreasing. And in the second year, still an improvement in kidney function is seen, even though they're receiving less medication. So none of these individuals in the second cohort have had to go on to a calcineurin inhibitors. That belatacept and sirolimus has been used in 12 of these individuals. 4 have required transition over to a drug called mycophenolate mofetil for intolerance to sirolimus. One of these individuals has been on sirolimus alone. 1 is now on belatacept alone. And 2 individuals are still in the process of weaning down. So of the 40 patients that have been treated with this new method, all of these individuals have experienced good outcome, and we've been able to demonstrate that this is applicable not only to live donor kidney recipients, but also deceased donor kidney recipients. Belatacept has been tolerated by all individuals in the trial. Sirolimus has been tolerated poorly by some, but we've been able to transfer those individuals onto mycophenolate mofetil. The renal function in this group has been excellent, and this regimen has allowed some people to transition to a single drug therapy that allows people to prevent rejection of somebody else's kidney by just taking one medication 1 time per month. Now you may ask, how do we know if those individuals even need that 1 time per month therapy? Well, we have looked at a couple of patients to determine if in fact those individuals can be taken off of their belatacept. This shows a flow cytometry plot across the top showing cells that are not stimulated with anything, and looking in the red boxes you see there's no activation. In the second row you see the individual responding against their donor, and prior to transplant you see that they can respond against their donor very well, but after transplant their response against their donor has gone away. In the bottom panel, you see the ability of the individual to respond against other individuals, not their donor, but other people. And you can see that their general immune responsiveness to other people has not been changed at all. This is a specific decision not to respond to the individual. Now, this individual that I'm showing you here was able to stay off of immunosuppression completely for almost a year. But at that time, the individual received a viral infection, probably the flu, and this inflammation stirred up response against the donor. So at this point, we don't think that people can be weaned completely off their medication, but rather that they should stay on a single dose of medication once per month, just on the off chance that they have an immune activation event, either the flu or a car accident or something along these lines. It's interesting that we have moved from trying to block immunity to actually now allowing immunity to occur in its natural progression, but simply block the context of danger toward the graft. So can we anticipate this? Can we determine which individuals will be good for this regimen and which ones won't? Well, we're just starting to look at that. And one of the molecules we're looking at now is a molecule called CD57. It's a molecule that was initially looked at in brain biology, but it's now been shown in humans to indicate cells that are deep in the process of activation. This cell, or most cells, don't express this molecule, particularly in healthy individuals, but in patients that have kidney failure, likely because of the exposure to dialysis membranes or to the many organisms that show up in a patient with renal failure's life, there are a lot of individuals that have this CD57 population present. We have found that individuals that express this molecule, shown in the red panel, actually are more likely to have rejection on belatacept than individuals that don't express this molecule. And indeed, we're now studying whether looking at this molecule before the transplant can anticipate who will benefit from belatacept therapy and who will not. This molecule is seen on many different populations of cells, not just memory cells, but also naive cells. So it's not just a surrogate marker for immune memory. It probably has some other function that still needs to be worked out. Suffice it to say, though, that when these cells are looked at carefully and we look at the genes that these cells make, these CD57 positive cells have a gene signature that matches the gene signature of acute allograft rejection. And in fact, these cells may be the fundamental source of kidney rejection that need to be controlled by our medications. So to summarize, transplantation remains in modern practice encumbered by its association with the requirement for many non-specific immunosuppressive agents. Certainly we can prevent rejection in almost everybody, but the consequences of that are the things we're most concerned about now. Co-stimulatory pathways, as opposed to other immune pathways, can be manipulated and allowed for relatively fine control against very specific antigens. And by doing this, we can control a response to alloimmunity, response to other donors, and indeed a regimen that uses this co-stimulatory blockade, in particular a drug called belatacept, when combined with the drug alemtuzumab and sirolimus, can prevent renal allograft rejection without having to use cyclosporin or other calcineurin inhibitors and without having to use steroids. This regimen seems to be well tolerated by people, and in fact, as the immune system regains its footing after this, that allows for a more permissive environment to prevent rejection, such that individuals can require less immunosuppression with time as opposed to more immunosuppression with time. And knowledge of a patient's immune repertoire when they come to the transplant may allow us to individually tailor the medications they require and ultimately prevent rejection without having to have people on medications that they don't actually need. So I'd like to thank the many individuals that have helped me put this report together, people in our lab, people at the institution where I practiced before I came to Duke at Emory University, and the many people, particularly in the federal agencies, that have helped support this advancement in transplantation biology. I hope that this was helpful in helping you understand some of the more modern advances in immune manipulation, and we'd certainly be happy to see you here at Duke or to entertain questions at some point. Thanks very much.